Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Tara Harrington, our Trauma Program Director at RUMC, and Dr. Vladimir Rubenstein, Trauma Medical Director at RUMC. Through RUMC Connections, you'll meet the fantastic doctors, nurses, and medical professionals that make our hospital thrive. We'll also provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. So trauma is the leading killer in patients under age 44. So trauma services involves the detailed assessment and care of injured patients. Richmond University Medical Center is a New York State Level 1 adult and Level 2 pediatric trauma center, which is the highest designation given for trauma centers. RUMC's emergency department is accredited by the American College of Surgeons, which means that RUMC services adhere to rigorous standards, ensuring the highest quality of care, including the ability to treat a high volume of patients 24/7, 365. RUMC also has board-certified subspecialists available in the areas of emergency medicine, orthopedics, neurosurgery, anesthesia, and plastic surgery to help care for injured patients. RUMC's trauma service also provides cutting-edge intensive care for injured as well as surgical patients. RUMC's state-of-the-art emergency department is fully equipped to handle all levels of adult and pediatric emergencies and has designated areas for triage, pediatrics, chest stroke care, trauma resuscitation, women's health, and urgent care, just to name a few. So as a Level 1 adult trauma center and Level 2 pediatric trauma center, RUMC is equipped to handle any medical emergency. At 958 square feet, to be specific, the main trauma unit is equipped to handle any medical emergency and provides adequate space for medical personnel to examine patients and immediately administer life-saving care. So it has enhanced lighting fixtures and rotating medical equipment stations that are just some of the features of the unit, and it's located adjacent to the ambulance receiving bay. Treating over 50,000 people annually, RUMC operates one of the busiest emergency departments in the New York metropolitan area. The 35,000 square foot facility is also a New York State Department of Health designated stroke and STEMI treatment center, as well as Staten Island's only sexual assault forensic examiner, Safe Center of Excellence. So today we'll explore the continuum of trauma care at RUMC from the moment a patient arrives to their recovery and rehabilitation. This episode will detail how the trauma center collaborates with departments like emergency surgery, ICU, and physical therapy. So Trauma Director Tara Harrington and Trauma Medical Director Dr. Vladimir Rubenstein will highlight some patient stories, discuss the integration of advanced technology and personal care, offering a holistic view of what sets RUMC apart as a Level 1 trauma center. So welcome back. Thank you for joining me again today.
Thank you.
So how many traumas are we seeing each year at RUMC?
We see over 2,000 a year.
Wow.
Each year. And that's mixed adult and pediatrics.
Okay.
Yeah.
And what are the most common traumas that you see at RUMC?
Our most common trauma, according to our data, is geriatrics, and the mechanism of injury are falls. So we see a lot of falls, a lot of geriatric falls. We see a lot of children falling off beds, falling downstairs. But yeah, falls is our biggest trauma.
Okay. I would imagine, playground injuries and so many things. Okay.
Especially this time of year, hanging
Right.
Christmas lights.
There are two things that keep trauma centers in business. It's the gravity and stupidity. Those are
Gravity
two
and stupidity,
things
that's right.
that provide us.
Yeah. Okay. Well, that makes sense. So what does the trauma care journey look like at RUMC from, the moment a patient arrives until they're discharged? What happens?
Well, that's part of my job is the program itself and really collaborating with everything that the patient has to touch. So we start with the journey is the EMS, when they are picked up and then they come in through the emergency department, labs, blood work, the trauma surgeons, the ER doctors, the nurses. They need radiology services where they make diagnoses from CAT scans or, chest x-rays and things like that. Then they can go up through the operating room and then to the PACU, which is the recovery room. Most times they go into the surgical ICUs. or the medical ICU, depending. And or after that, they'll go to one of our med-surg floors, mostly like our step-down seat 3-1. Then from there, we start, the minute that they're there, we already start with rehab services and consultations and things like that, what the patient's going to need. This care coordination where they have the nursing team there that helps them, will they need to go to some sort of a rehab facility, or will they be able to go home, and what services they would need at home. So it starts from the injury, and we get them right back. We keep them through right back. Dietary, nutrition, big deal. Get them right into reacclimation to their lives and what that looks like and what services they would need to help them get back on their feet.
Yeah.
So it's a long journey, but we have every service that they need there, and we're able to move them through, and with a lot of success and really good outcomes.
Yeah. Perfect. You need good teamwork.
Yeah.
Okay, so what are some things that the public may not know, is involved in maintaining a level 1?
When I worked in the emergency department, I knew how to do a trauma. It was, that was part of my my work day, but I didn't realize it, and I don't think that the public realizes that, as an academic institution, you have to have published articles by members of the trauma team, people within the hospital. It has to be research that's done and published. So we have to have, in a 3-year span, we're looked at every 3 years by the American College of Surgeons. So we were looked at in 2023 and certified, verified, and we'll be looked at again in 2026. Within those 3 years, we have to have 10 PubMed ID, published articles for research, which we collaborate with every department, and we make sure that somebody's doing the research. And actually, we've had a lot of success with that. We've really worked on that a lot. I think that people don't realize that you have to have a certain amount of admissions to the hospital. You have to have, to maintain your level 1 status. I've done a lot of verifications in my career. It's a very rigorous verification. They want to make sure that RUMC is exactly equipped and able to do what every other, if they're going to put their name on at the American College of Surgeons, they want to make sure that the hospital in Kentucky and the hospital in California and Florida, that we all are falling under the same standards. So there's 110 criteria that we have to follow. Wow. We go through it. They give you a book, and then we just make sure what we do is we make sure that we maintain it, and that's an everyday process. And performance improvement is something that's really big. We make sure that what we did was right. And if we can, you could always do things better, but we want to make sure that, we did it correctly. And then how can we do it better the next time? So we look at that. So that's always a big thing. What did we do to make sure that it's something, and it could be something very simple, but that it doesn't happen again the next time. I think that that's what a lot of people don't realize, that it's an everyday grind of keeping this program going and making sure that everybody's on their game, and that we maintain these standards that they require, so that when they come back in 2026, they see that we are, eligible and to be verified by the American College of Surgeons for them to put their name on us. So
Right. I mean, it's just like Tara said, it's a very rigorous process to become verified. American College of Surgeons is a great organization, and the standards that they're set for the trauma centers are very high, and it takes a lot to meet those standards. I mean, there's a book, has all the criteria. I don't know, you said 100. I think there's like 200. There's 110. What was like 200? So
feels like it.
Right. You have to meet all those criteria.
Yeah.
You have to have a buy-in from every department, because trauma.
Yes.
It's not just the trauma surgeon, it's the radiologist, it's the emergency room physician, it's the neurosurgeon, it's the orthopedic surgeon. So the care of a trauma patient encompasses all the specialties, and all those specialties have to buy in, and they have to meet those criteria too. So it really is a team effort, and it's hard. It's very hard.
It is hard. I mean, it's the hospital that's verified.
Yeah.
It isn't just the trauma team. It's the hospital that's verified as a level 1 trauma center, because it's the whole center that's involved in the care of the trauma patient. It is, it isn't just, well, the patient went into the ER and they were a trauma. It's everybody. So we get buy-in from everybody. We have meetings, we have reviews, we get liaisons from every department to make sure that they know that this is the standard that they have to keep, and they're responsible for it. And then, like we said, the rigorous verification, they will go through every department, and to make sure that you have people that are certified, and they they look at certifications, they look at education, they look at trainings, and it's very rigorous. But these high standards need to be kept because
Of
when
course.
that's where you want to go. You want to go somewhere where
Right.
you know you're going to get the best
Exactly.
care. Yeah.
Well, that's very informative for the public to hear something like that. That's not something that many people would just know offhand.
Yeah.
So
Yeah.
it's comforting,
Yep.
to know that when people come to RUMC that they are receiving the highest standards of care and that you're, meeting those protocols year in and year out and,
Yes.
and maintaining, those criteria. That's wonderful. So now, what are your roles in ensuring that a patient's journey is as smooth and effective as possible?
As the director of the program, that is my role.
Yeah.
Is to make sure that I collaborate with every department and that they are maintaining the standards. And it goes from paperwork to temperature controls in the rooms to making sure you have enough blood on hand. And so I think for me, my role is just making sure that every liaison, every department, that they meet the criteria that's set. And like I said, it's an everyday, and also work with them on how we can improve, because we're constantly trying to improve, improve our patient outcomes, improve the hospital stay, improve there's so many areas that, like I said, we were talking about getting our hips to our fractured hips to the OR faster, and it's or getting blood products up faster, or making sure that vital signs are done correctly. So there's a lot of clinical aspects of it. So that's my role.
I think Tara is the glue that keeps the program together. And my part, outside of direct patient care that I provide, I do kind of supervise the other surgeons. I won't say even supervise. I try and help them, and I look over their cases and make sure that the standards are met. And if we have a problem, we address it. That's sometimes it's a system problem, meaning the system didn't provide. Maybe there's no equipment is missing, something's missing that needs to be addressed. Or sometimes it's a provider problem where the provider needs to be educated. So my role is to make sure that those standards are met. The providers, they're doing their job. And I gotta say, for the most part, we really didn't have many problems. Everybody is doing what they're supposed to do.
Yeah.
Oh, definitely. And how many trauma surgeons are there at RUMC?
There's 5 of us that they're on a call schedule right now. And actually, we have a very good mix, because actually 2 of the attendings actually trained me.
Oh, wow.
So we have experience, and then the other 2 attendings are juniors, meaning they have some experience, but they recently graduated, and I'm kind of in the middle. So I seem to kind of mesh well with we mesh well together.
That's important.
We have really good relationships, and just as an example, if somebody's in the operating room and trauma comes in and they need help, I'll show up and help them, and vice versa. If I need help, they'll come and help me.
Yeah, which we just did have that last
Right.
week.
Yeah.
A couple of weeks back we had where there was it was a big trauma, and not only did Dr. Rubenstein go in and help the trauma surgeon that was there on call, but then we had another trauma surgeon who was in-house who also went in, and then we had our thoracic surgeon went, a vascular surgeon. So
Right.
everybody went
Everybody's
in because,
all
and they,
hands on board.
Yeah.
So all hands is right. So
Yeah.
we're lucky to have the people that we have in that hospital. And I think that that's something that the public should know, because we really do have very good surgeons.
Dr. Rubenstein, how do you prioritize injuries when, multiple traumas are involved?
Right. It takes experience, but I'm actually an ATLS director, so I teach ATLS class, and actually part of that class is actually triage scenarios, and it gives you and the main idea of that is that the injuries that take precedence, meaning like life-threatening injuries that can be addressed right away, for example, like punctured lung, those will take precedence over somebody who has maybe fractured arm.
Yeah.
So basically, triaging patients, especially if you have mass casualty event, you have to have really good, you have to have experience, which is something that I have, and have to have good understanding, and like I said before, just making the diagnosis. There's not in the trauma field, there's not the main life-threatening diagnoses that are there. It's punctured lung, it's the blood in the chest, it's the cardiac injury, it's the injury to the airway. So those are the things that you need to address right away.
Okay.
And that's how you will triage the patient. Whoever has the most life-threatening, most immediate injury, and the one you can address right away, that's how you prioritize.
And I think lucky for the surgical team, we have an amazing nursing staff that they're critical thinkers, and they have really good assessment skills. And so they're able to assist them to say, I think you need to look at this one as opposed to this one, So lucky for us, we have experienced, educated, like I said, critical thinkers
Oh,
as
that's
nursing
helpful.
as the nursing staff. Yeah, that really helps prioritize patients.
Okay, perfect. How do you, handle these mass casualty events where, multiple trauma patients arrive simultaneously?
I think the first thing is they activate overhead and they
Okay.
let the hospital know that there's mass casualty coming in or has arrived at the hospital, and then it's assessing the patients when they come in and prioritizing worst to not as critical. So we look at the critical patients first, make sure that they get on their way to where they're supposed to go, and then it goes from there, down to the least. Somebody walking around and didn't really have a mechanism of injury that we should be too concerned about. So.
Yeah.
Right. And you have to be prepared. I mean, but the good thing about RUMC, we're kind of like a family. So, if there are a number of patients come in, we can always, get other surgeons to, to help. Everybody comes in, everybody's going to help.
Yeah.
And whatever needs to be taken care of, we'll take care of it.
Have you ever dealt with a very large mass casualty incident?
We've had. I don't think we've ever been overwhelmed. We had multiple patients coming in, like 2-3 patients that require going to the operating room, and we have multiple surgeons that come in and we'll take the patients to the operating room. But it was never a point where the system was overwhelmed.
That's good.
We're prepared. We have the OR team that's on call. We have backup teams for them, and then if they go in, we have a backup team for that. So we're prepared as far as
There's always backup.
Yeah, there's always backup. So we've had some car accidents and things like that where, but nothing totally overwhelming. We practice like we are going to get one, but we haven't yet.
Yeah.
Thank goodness.
And what role does the triage nurse play in ensuring that patients receive, the right care quickly?
Yeah, I think that's the most important role is that they have to be able to be experienced enough to pick up the subtle signs of things that they think could potentially cause them, worse harm, and understand their mechanism of injury and what potentially could be wrong with them. So they play a very important role. They're really the ones that are organizing and discussing and collaborating with the physicians to make sure that people get the priorities, prioritized correctly.
How do you ensure that family members are supported and informed during the critical early stages of trauma care?
Well, we allow family members, and as a matter of fact, when there is a trauma, there's a lot of studies that show that having the family in the room helps with the grieving process. If God forbid, the patient, they do lose the patient, it does help knowing that when they think back during their grieving process, they know that everything was done because they were there and they saw that we were doing everything possible. We're lucky enough to have a very strong social work department, and we have a lot of social workers that would come down. There's a beautiful room in the back of our new ER that we would bring the patient and their family to make sure that they're there and they can get the services that they need, phone calls, food, anything that they need. But emotional support, is really a big driving force there, and you'll always find somebody that will be able to go and sit with them. But like I said, social work really will take over that part. But it's very important to have them, to let them know that, and let them, if they're able, let them see that we are doing everything possible to help their loved one.
Okay. Do you ever find that the family could be a hindrance, that they're
Yes.
too hysterical?
Yes. So, listen.
Imagine it goes both ways.
It does go both ways, and there's a lot, you just have to kind of take it, individually. And if you think that, somebody's going to pass out or faint, or if they're making, then they're removed from the room. And, but, lots of times they do want to stand there and watch. And I think I think it's important for them, in the, God forbid they lose the patient. I think it's very important to have the family involved. So we have a nice, we do have a nice support system, and we have a good plan in place for that. Yeah.
Okay. Can you describe the process of transitioning a patient from the ER to surgery or to the ICU?
The process is quick, and trauma comes in, and you have to figure out if the patient is seriously injured and what those injuries are. Once you make a decision whether you're gonna take the patient to the operating room, the process is basically immediate. The elevator is right there. So from the trauma bay, once you resuscitate the patient, did whatever you needed to do, you take the patient to the elevator. Basically, it's one floor up, and you're in the operating room. And the operating room is ready. And this is the golden hour. This is the golden minute. And it's very quick, and that's the way it's supposed to be.
Perfect. Yeah. No, you want it to be as fast as possible. And so what are the common, complications, that arise during surgery, and how do you mitigate them?
Trauma cases, they can be very difficult, and because it's not an elective operation. When you go in for an elective operation, you kind of know, what to expect, and you already know what complications can come up. In trauma cases, things can get very complicated because patients have multiple injuries in multiple areas of their body. And as a trauma surgeon, you have to, you really you don't want to miss anything, and you kind of have to sometimes step back and just think before you act. And while if you're in an operating room, you're operating, and the other thing you really kind of have to keep in the back of your mind, you have help.
Yeah.
And it's not a weakness to call for help. And a lot of surgeons don't want to do that because just the culture of surgery is that you're a surgeon, you have to take care of it. But as an experienced surgeon, I can tell you that getting an extra set of hands in there, getting somebody to help you, your colleague, it really gives a whole different perspective. Because when you're operating, when you kind of caught in the trauma, sometimes you can't see forest behind the trees. So if you get that help, you get somebody to help you, it can make a big difference. And it's not a weakness. I think it's a good collaboration.
Oh, I completely agree. And I mean, like you said, it's not something that's, a pre-scheduled procedure where you know what
Controlled,
to expect. Where a gunshot or a stab wound, an inch to the left or the right, could involve, an organ or, something. It could, the positioning of these injuries, I'm sure, makes a great deal of impact on, the level of care that they'll need. Okay. Can you explain, the importance of damage control surgery in trauma care?
Right. This is a very clinical question. It's a good question because I like clinical stuff. It's a good question. So damage control is it basically for a trauma surgeon. We're also general surgeons, so most of our operations are done on the abdomen, and we do go in the chest once in a while. We operate in the neck. We don't operate in the head. Neurosurgeons take care of that for us. But damage control is the idea of trauma is that you have to stop the immediately life-threatening abdominal injuries such as bleeding. So you stop the bleeding, whatever contamination is there, you stop the contamination, and at that point you stop the operation and you basically continue what's called resuscitating the patient. I mean, you provide patient with IV fluids, blood products, and let the body catch up, because if operation itself is a stress to the body, so you just want to stop the injury. You don't want to continue to stress the body. You stop the injury, you let the body recover, and then you do definitive care, meaning then if you need to reconnect bowel or you need to fix things like they're not life-threatening, you do that at a later time when the body is recovered.
That makes sense. And what is the governing body overseeing the trauma program?
It's the American College of Surgeons.
Okay.
Yes, it is.
It is. Okay.
And they are very rigorous, and they have a lot of criteria, and we follow it just like every other hospital in the United States that is verified by the American College of Surgeons. We make sure that we meet every criteria and every standard that they have. It's not easy, and it's something you can't be complacent upon. You have to really stay on top of, and we do.
Okay. What role does the trauma program play in coordinating with different departments to ensure continuity of care?
I mean, I think that they play a very big role. And like I said, we touch every department in the hospital. So there's meetings that we have. We have trauma committee. We have a trauma committee, and it's a liaison from every department. And we have trauma committee meetings, and we make sure that we give all of our data to them. We let them know where we're at as far as any sort of performance improvements that we're trying to take on, and we talk about the standards that are met, and verification from the American College of Surgeons is always a big hot topic because we want to make sure that we're ready for them. Even though we were verified in 2023 and we're not going to be looked at again until 2026, we're continuously getting ready for them, making sure that these standards are that we stay on top of everything. So it's a big role for the trauma program, and we have to make sure that we collaborate with every department.
Okay. What are some of the most complex trauma cases that you've dealt with, and how did you manage them?
I mean, well, number one, if you have injuries in multiple areas, it's sometimes difficult to prioritize. You want to address the life-threatening diagnosis first. Things can get confusing. If patient has injury to their soft tissue of the extremities and they're bleeding to their abdomen, and you operate in their abdomen, but at the same time, somebody has to take care of the arm also, and it's serious injuries in multiple areas, and you have to get help. You have to call for help. I had a case recently when patient had really bad injury to the extremity, and it was involved both the bone and soft tissue. So we had and vessels. So
Wow.
we had to have a vascular surgeon, we had to have an orthopedic surgeon, and a plastic surgeon, and everybody had to work together. And there are multiple surgeons involved at the same time, operating on the same extremity, and they have to prioritize. You have to fix the vessel first to make sure the blood flows there. Then you have to fix the bone, and then you have to fix the soft tissue. So things can get very, very difficult and very complex very quickly, and you have to be prepared. I think experience definitely helps.
Yeah.
Every time you do something over and over, it becomes easier for you.
Really what it comes down to is just prioritizing and being prepared, and making sure that you can think what could possibly go wrong in this situation.
Yeah.
It's that critical thinking that you have to have. I've been involved in a lot of traumas, a lot of gunshots and stabbings, car accidents we've had. And I think it's just a collaboration of everybody coming in and working together. Yeah. And that's what they do best there at RUMC, is that they do work well together.
A great team. Perfect. So what role does mental health support play in a patient's recovery, and how is that integrated into the trauma care journey?
Yeah, we have behavioral health. We look at, obviously trauma is called trauma for a reason, and it's not only just physical trauma, but it's mental health trauma. And so we collaborate with Staten Island Mental Health, and we make sure that for any PTSD, they have quick follow-up. They're seen by the social worker and evaluated for such issues. As they're going through, even if they're in the hospital stay, they're visited by somebody, or there's a plan for them to follow up to make sure that that part of the trauma and their mental health is met.
Yeah.
And again, there's Davy Jones.
Jones,
Our dog that comes in.
And he comes to the patients too?
Yes, he does.
But there was a second dog. What was the second
Oh,
dog?
now we have Maisie.
Oh, yeah.
We just got Maisie. We have two
Maisie's
dogs.
the standard poodle,
Yes,
right?
yes.
Oh,
So
yes.
she's here, and one is Tuesdays and one is Wednesdays.
Oh,
so
very nice.
I know, and people look forward to
Yeah.
having, and not only the patients, but like I said, it's really good for the staff.
too.
Really good. They do look forward to having. It sounds like so simple, but it's just that little. It's odd to see a dog in a hospital.
Yeah.
So when they do, we have a lot of dog lovers, and they
Yes.
love to just, gives them a little bit of a smile. So of
course.
yeah, it does help.
Nice to add some
Yeah,
brightness
it certainly
to
does, yeah.
these traumatic moments.
Exactly,
Of course,
exactly.
Of course. Are there any community resources or programs that RUMC partners with, to aid in long-term recovery?
We are, Staten Island Mental Health, we partner
Okay.
with them, yes, for sure. We have, and then there's a lot of relationships that, like care coordination with nursing homes and adult homes, and physical therapy at home, visiting nurse at home, and things like that. So we partner up. Once they go home,
Yeah.
we don't want them to think that that's it, that we've forgotten about them.
No.
So we make sure before they're discharged, which I think is a really big process for our care coordination, but we make sure that they are well, they have the appointments that they need, and they make sure that we have really good follow-up for them, because the care can't just stop as soon as they leave, because they're going to be, it's scary, I'm sure, to go back after having such a big event happen in your life. So so we partner with, like I said, Staten Island Mental Health and a lot of the little adult homes and nursing homes on Staten Island. So,
Okay.
yeah, for rehab.
Perfect. So what final message would you like to share maybe with trauma survivors and their families? Is there anything?
No, I think
I have to say, there are resources, right? That we're here to help you.
Yeah.
I think that's the message, and we've done a lot of work to get the best care to the patients on this island, and we have the best surgeons. I think, in my mind, they're definitely the best surgeons, and I've worked with them for years, and I've seen really good outcomes and a lot of grateful patients, and the resources are there. There are a lot of people involved, and everybody's trying to help. And I think we're good. North side of the island is taken care of. That's the
I
message.
have to agree. Yeah, if anything were to happen, this is the place to go because we don't forget about you after your discharge. We make sure that once you're there, that your stay is exactly the way that it should be, and that your outcomes are positive. And we do everything that we can to improve and to make sure that our standards are met. So I think we have, I would put our staff and the ED staff and the OR staff, I'd put them up against any hospital in the United States because we really are.
They're a wonderful team.
They are a wonderful team. So I think that's really the message.
Right.
If you're on the North Shore, you're covered.
Definitely.
Or you have to drive from the South Shore to the North Shore.
Yes, it's worth the ride.
It is worth the ride.
We'll take care of you.
Yes.
Absolutely.
Well, thank you so much once again for all that you do to keep our community safe and well. We are very grateful to have such a wonderful trauma team at RUMC. And if anybody would like to learn more, they can call 718-818-2942 or visit rumcsi.org. That about does it for this episode of RUMC Connections. I'm Meredith Gaskins.
Thank you.
Thank you.
for having us.